Hi, my name is Kira Niederhofer, and I'm presenting on behalf of my team at the Duke Institute for Health Innovation about our project building a machine learning model to predict hospital admissions and emergency department visits in patients taking immune checkpoint inhibitors. Immune checkpoint inhibitors are a class of cancer therapy which have revolutionized treatment in the past 10 years. You may have heard of them recently in the context of this study from Sloan Kettering, which produced snappy headlines like these. Dramatic results like these have followed immunotherapy since its introduction. The therapies are now used across a variety of cancer types and stages and represent a chance for cure for even patients with metastatic disease. Immunotherapy works by activating the body's own immune system, removing a cancer's ability to evade targeting and destruction. But enhancing the immune system comes with unintended consequences. Immune-related adverse events occur in up to 80% of patients who take immunotherapy and can range from mild diarrhea to life-threatening adrenal crisis. Categorizing these events can be difficult because of a lack of standardized nomenclature or ICD-10 codes. Our group built a machine learning model to identify which patients are most at risk of immune-related adverse events to allow clinicians to target them for intervention in the outpatient setting before they require emergency care. Here's the scope of the problem at Duke. Of the 3,962 patients who started checkpoint inhibitors between April 2016 and July 2021, 9.4 were admitted to the hospital within a month of starting therapy. By 6 months, 33% had ED visits or hospital admissions. These outcomes contribute not only to significant morbidity and mortality, but also increased costs for patients and hospitals. Here are the model parameters we used. Our outcomes consisted of all ED visits and hospital admissions for adult patients on immunotherapy. We considered data from time of initiation until 6 months later, until death or immunotherapy cessation, whichever came first. Our score updates weekly and predicts the risk of outcomes within the next 2 weeks. Cohort demographics can be seen on the right. We input over 300 model elements into our model, including common labs and analytes, vitals, details of the specific medication, their cancer course, and comorbidity data, as well as demographics and orders. The model was trained using a gradient boosting model framework and yielded an AUC of 0.76. On the right is the importances of the various elements in our model, and I've called out the top 20 most important elements on the right. We spend a lot of time on implementation of our model so that the risk score we generate is actually useful in clinical practice. Briefly, the score centers around the primary oncologist, who is the last provider to see the patient in outpatient clinic. That provider chart reviews and contacts the patients to update symptoms, assisted by clinical staff when available. And it's that call that determines what intervention they take. Interventions could be education on when to seek emergency care, on symptom management, or could be scheduling the patient for a next day visit in the acute care clinic. Thanks very much, and I hope to talk to you in the poster session.